patients and citizens will be able to say what they need to keep people well, physically, mentally, emotionally, and spiritually.
The room and see marginalized or different identities that we see here. LGBTQ, trans, Black, Indigenous, they are not part of this conversation.
Mental models signal how to act from a social norm sort of thing, but also how to act when we consume information. So bias tends to drive behavior in the absence of an intervention. Changing underlying mental models changes belief in bias.
We're not basing investments on how the system's going to be better. We're not bringing that forward into how we hold people accountable.
Everyone wants to fix healthcare until you try to change something.
Healthcare system that puts their needs first. Sustainable and accessible for everyone.
We need to recognize our populations are changing. We used to have this idea that we were one big nation, but there's lots of different groups.
And across areas, we should be doing that always with this focus about how we're increasing value.
Targeting what matters to the person. How much does it cost, not for one intervention, but the entire trajectory? We should be measuring value and using those measures to make better decisions.
Building trust, which involves transparency, inclusiveness, more tables, is a critical step forward.
Everything in healthcare should be called value.
We assumed safety was a priority for the system, that the system will do anything to make safe care possible. We know that's not necessarily the truth. It amazes me the number of times we talk about initiatives in healthcare and it's not grounded in the need.
Historical traumas that were really starting to come in the 1960s. We were sent away for school at a very young age. I was 10 when I was sent away for school. 2 years with a family in Nova Scotia, 3 years in a residential setting where 200 Inuit children were sent from Nunavut to Churchill, Manitoba.
So with the housing first and the prevention work, Helsinki, like I said, has more or less ended street homelessness.
I used to assume I had no issues being discriminated against, and I found out how wrong I was. My gender impacted my health services.
And being stereotyped not by the way I looked or my clothing or how I presented myself, I was stereotyped and labeled as, an alcoholic or a drug user based on when my provider asked me what my nationality was.
I struggled to pay my rent with minimum wages. After 1 month notice, I still couldn't find a cheaper place and was pushed into the street. I became homeless with a full-time job.
Having been sent away on a ship, being hospitalized for an extended period of time was re-traumatizing for my mom.
Rough or unshelters is up 100%. The raw reality is that being unhoused is by definition, meaning that at some point you will deal with seriously ill health in Canada. We have a home healthcare system unable to deliver care for people without homes.
Triggers, well, what kind of triggers am I talking about? These are smells in a hospital, they're the noises, there are procedures, there's needles, there's being given a pill, actually taking the pill when your experience has been that those things were forced on you. You're going to associate that intervention, that medical intervention, nursing intervention with pain.
300 years of colonization and ongoing trauma, unhealthy living environments due to disempowered communities, due to colonized communities, puts Indigenous people at a higher risk of being infected.
Healthcare professionals and administrators must reflect the diverse communities that they serve. This will help break down cultural and linguistic barriers and promote trust.
In my experience in adult literacy, low literacy levels affect health. You can't read a prescription. You can miss vital information about medication. A woman accidentally took her husband's medications and wound up in a coma. I find that information given by pharmacists tends to be written at or above a grade 8 level. But 48% of Canadian adults have difficulty reading at that level.
This, always leaves the question of, can we afford what we're doing, or can we afford done house? And I think the argument would be we can't afford not to do this at scale. We cannot afford the status quo. Someone staying a month at the hospital that I work at is over $30,000. The provincial jail costs, which my dear friend Lana Fredo calls the de facto mental health system, because people have nowhere else to go and end up in the justice system, especially for racialized populations. The provincial jail cost is close to $15,000. Sheltering now has come down a bit to probably $7,000 since the pandemic, but it's still almost double the cost for supportive housing.
Keeping people in poverty, using your voices as patient groups to advocate and bring those stories forward.
Homelessness, because we know that the health outcomes for people will get significantly worse the more that they are within homelessness. But we know also as well for lots of other folks for different reasons, different health reasons, that supportive housing is something that is vitally needed, but unfortunately quite absent.
The Indigenous population is highly diverse in identities, experience, and connection to culture. It's essential we provide culturally safe, trauma-informed care.
Data should follow the patient so we can make better decisions.
There and actually helped advance some work around the patient's health declaration of health data rights. So that was, which I was utterly thrilled to see being published earlier on this year, because I think that is really important for patients and persons in Canada to really make it clear what your expectations are for your health data in the context of its use.
A lot of hospitals have more huddles, but they spend far less time in those huddles because they're not running around trying to get information. They're spending that time using the information on the screens, making decisions, not just collecting data to then try and make a decision.
We need coordinated efforts sustained across all Canadian jurisdictions. None of us can be left behind in the data dark ages of paper records, missed voicemails, and the infamous fax machines.
Our collective health data is aggregated to figure out the health system and form the basis for policy and practices.
Building trust, which involves transparency, inclusiveness, more tables, is a critical step forward.
As patients, advocates, and allies, we can redefine the future of healthcare in Canada. It is important to be part of the conversation for our children and grandchildren and next generations.
There's value of engaging patients. You want to reduce rates, costs, improve quality. There's a lot more recent work that really talk.
And listen to the culture cues, understand people's circumstances, and we move on with the people that we serve together, co-creating a treatment plan or any action plan that change their lives.
Many of us were here 15 years ago and the talk was about a national pharmaceutical strategy, real world safety, special access program. We had an Office of Consumer and Public Involvement that doesn't exist anymore. Why did they fall apart?
We need a learning health ecosystem that works for everyone. To get there, we need patient engagement.
The challenge of patient engagement is to include diverse perspectives. Our systems have been built upon structures of oppression. Who we are, the place we occupy, our ability to access resources, we created our society to be unequal. And when we drive patient engagement through these systems, we reinforce those structures.
We're focusing on the outcomes that matter to those patients. So the African proverb says, if you want to go fast, go alone, but if you want to go further, go together.
That we serve. So this approach goes beyond the concept of physical health or simply the absence of disease. It is about nurturing the whole person and recognizing that true health involves balance across all dimensions of life. So our model is firmly rooted in a population's needs-based approach to healthcare planning, and we incorporate Indigenous-informed evaluation methods and scaling leading practices to achieve excellence in Indigenous health.
In the need for teamwork in healthcare in order to deliver safe care. And then in order to have teamwork be possible, we need access to everybody on the care team needs access to information and the ability to communicate between the care team.
So we're working with several provinces to get initiatives going around diagnosis and speeding up diagnosis through navigation, dedicated pathways, or dedicated clinics for that, as well as things like hub and spoke models, where care could actually be given in smaller centers closer to home, and not all have to necessarily be brought into a specialized center.
If we don't have an integrated system, we don't create a place where people can see those payoffs, and will continue to underinvest. We need to look at investment across the continuum, integrating that continuum.
Without mental health, there can be no true physical health.
Technology does have the potential to increase access to care and can be quite positive. But we use remote presence that I was talking about. What it meant was that the patient was talking directly with the specialist or with the doctor, and that the nurse or the doctor listening in and being able to hear directly from this provider makes a big difference.
So when I think about culturally responsive healthcare, and making it, how we make it a reality for all Canadians, it's an individual responsibility to make the shifts, but there's also a collective responsibility to make the shifts.
We see the way forward as one where we have decision-making tables that are inclusionary, where we have an ecosystem for equitable patient engagement, the cornerstone of a learning health system.